Okay, so welcome everyone to the second lecture of endocrinology for Dr. Hadi Step 1. Thank you so much for joining the lecture. Hope you guys are doing well. If you guys can hear my voice, can I get a yes in the chat box, please? Okay, good. Can everyone else hear my voice? Okay, good. So before we begin the lecture for today, can we do a quick revision and recapitulation of the topics from yesterday? Yes or no? So let's begin with a little bit of revision and recapitulation of the step 1 endocrinology, which we started yesterday. And at the same time, give the other students some time to join the lectures. Let's begin with embryology. Thyroid. Can anyone tell me over here very quickly, where is the thyroid developed from? Is it ectoderm, mesoderm, or endoderm? Endoderm. There we go. Okay. And if I had to ask you, the thyroid diverticulum, does it arise from the foregut, midgut, hindgut? From which portion does thyroid diverticulum foregut? Very good. Okay. Next question. What is the differentials of an anterior midline neck mass that does not move with swallowing or protrusion of the tongue? Very good. Persistent cervical sinus, anterior midline neck swelling that does not move with protrusion of the tongue or swelling is persistent cervical sinus. Very good. Okay. Now, next one over here very quickly is if I have to ask you about the name of the carrier proteins which the posterior pituitary uses to secrete ADH and oxytocin, what is the name of those carrier proteins? Neurophysin. It's not synaptophysin, it's neurophysin. Very good. Okay. Very good. Neurophysin. Okay. Next one is what is the name of the what is the name of the hormone that increases when a patient is suffering from, let's say, pneumonia? So there's a patient who comes to you. Okay, so here's this question out there. There's this patient who comes to you with a history of pneumonia. Now, you see that the patient has sodium level of 130. Now, is this hypovolemic, hyponatremia, hypervolemic, hyponatremia, or euvolemic hyponatremia? Quick answers, please. Hypovolemic, euvolemic, or hypervolemic? Very good. The answer is it's euvolemic. The answer is it's euvolemic hyponatremia because of excessive secretion of ADH. Oh, very good. Next one is if there's a patient who comes to you with weight loss, fatigue, hypotension, electrolyte disturbance, and hyperpigmentation, then what is your differentials? What are your differentials? Or what is your diagnosis? Adrenal insufficiency. If it's a patient from a developing world, then what is the most common cause of primary adrenal insufficiency? TB. Very good. If it's from a developed world, if the patient is from a developed world, then what is the most common AI? Means artificial intelligence. Yes. Autoimmune. Very good. Okay. Okay, good. Next question is what is the, if you have a patient with a prolactinoma Will the patient suffer from delayed fertility or infertility, decreased libido? Yes or no? Yes, very good. Okay. Next one, next question. What is the name of the hormone that gets converted to its active form after binding with protein in the liver? The name of the active form is somatomedin. Very good. IGF, insulin-like growth factor. Okay, good. Next one, next question is, you have a patient who comes to you, a female patient who comes to you with a history of having secretion from the mammary glands. The patient had a history of schizophrenia. The patient was being treated by first generation antipsychotics. What is the most common cause of the breast milk secretion or secretions from the mammary gland? Side effect. Can anyone explain the side effect very quickly? Please write me in the chat box. Can anyone explain the side effects? Dopamine antagonists, antipsychotics. Very good. Okay. Amenorrhea. Low dopamine increases prolactin. Very good. Right. So with that being said, are we ready to begin the lecture for today? Yes or no? Okay. So today, what we're going to do is we're gonna start the lecture over here with the discussions of parathyroid hormone. The discussions of parathyroid hormone. Now, parathyroid hormone is one of those hormones for Usmle step 1 and step 2 CK that is exceptionally high yield. So before I jump into the lecture over here, before I jump into the text over here from the first aid, let me just use the blank page very quickly so that we can talk about the parathyroid hormone. Is everyone ready? Yes or no? Is everyone ready for today's lecture? Oh, good. Now let's begin. Let's begin with BPH or parathyroid hormone. This is an exceptionally high yield hormone for your USMLE step 1. The amount of questions which you will receive about parathyroid hormone is immensely high. Now, number one is source. Where is the parathyroid, or where are the locations of the secretions of the parathyroid hormone? Number one is source. When we talk about source, the source of parathyroid hormone is basically they are secreted from the chief cells. They are secreted from the chief cells of the parathyroid gland. Now we know that the parathyroid glands are just near the locations of the thyroid gland, and the most common cause of parathyroid deficiency is having a history of thyroid surgery. Yes or no? If there has been a history of a thyroid surgery, then the most common cause of suffering from a parathyroid deficiency is history of a thyroid surgery. Number one. Number two, the most common cause of having increased secretion of parathyroid hormone is having a parathyroid adenoma. Okay, so now we have covered the two most common reasons for which the patients, they usually suffer from decreased parathyroid and increased parathyroid. Increased parathyroid is due to parathyroid adenoma. Decreased parathyroid is due to having a history of thyroid surgery, exceptionally high yield for USMLE step 1. Another thing that should immediately come to your mind when you see a question about increased parathyroid, the number one thing that should come to your mind is multiple endocrine neoplasia for USMLE step 1. multiple endocrine neoplasia for USMLE step 1 and parathyroid is exceptionally high yield, especially multiple endocrine neoplasia type 1, yes, and type 2A. MEN1 and MEN2A. These are two pathological conditions where parathyroid secretion is exceptionally high due to the presence of having a parathyroid tumor, especially an adenoma. Okay, now in MEN1, we know, can anyone tell me over here what are the criteria of having a MEN1 or multiple endocrine neoplasia type 1 tumor? Yes or no? Can anyone tell me the three, very good, 3 Ps? Okay, Dr. S, is this your first class with us or have you been with us from before? 3 Ps? Dr. S, is this your first class with us? First class, okay, good. 3 Ps, very good. So by 3 Ps, I'm pretty sure you mean that the patient is suffering from pituitary adenoma, pancreatic neuroendocrine hyperplasia, and hyperparathyroidism. Yes or no? Hyperparathyroidism. Is this correct or not? Yes or no? Is this the correct answer or not? Yes. Okay, yes, good. That is MEN1. And let's talk about MEN2. MEN2 is NPH. Yes, with NPH, you have medullary thyroid cancer, parathyroid adenoma, my apologies, pheochromocytoma, and then hyperparathyroidism. Okay. Is everyone clear about these 3 informations? Number 1, the source of parathyroid is chief cells. The number 1 reason for having a parathyroid deficiency is a history of a thyroid surgery. The number 1 reason of having excessive secretion of parathyroid is a parathyroid adenoma. Whenever we see increased parathyroid, the number 1 pathology that should come to our mind for USMLE step 1 is multiple endocrine neoplasia, especially MEN1 and MEN2A. MEN1 is hyperparathyroidism associated with pituitary adenoma, and pancreatic neuroendocrine hyperplasia, meaning this could be an insulinoma, glucagonoma, somatostatinoma, VIPoma, and MEN2A, that is NPH, that's medullary thyroid carcinoma, pheochromocytoma, and hyperparathyroidism. We'll talk about these pathologies and details in the future, but I'm just talking about the high yield associations of hyperparathyroidism for USMLE step 1. That's that. Now let's jump into the number 1 sign symptom, meaning how will you diagnose a patient of hyperparathyroidism? Can anyone tell me the name of the electrolyte that increases with hyperparathyroidism? What is the name of the electrolyte that increases with hyperparathyroidism? Is the sodium, potassium, calcium? Fast answers, please. If parathyroid increases, which electrolyte increases? Very good. The answer is calcium. The answer is calcium, very simple. Now, parathyroid is extremely sensitive to the levels of calcium. The stimulus, the normal stimulus for the release of parathyroid hormone from the chief cell is calcium, serum calcium concentration. Now, if there's a patient who is suffering from hypocalcemia for any reason, we know that the normal level of calcium should be close to 10. If it's anything less than 8, then the chief cells of the parathyroid are activated and they secrete parathyroid hormone. Now, when the parathyroid hormone is secreted, they increase the calcium level in the blood by a number of different types of mechanisms, which I'll talk about very soon. Before I do that, let me talk about the sign symptoms of hypercalcemia so that you can easily diagnose a patient of hyperparathyroidism. Number 1 is abdominal pain. Can anyone tell me why a patient of hypercalcemia will suffer from abdominal pain? Because hypercalcemia is associated with calcium phosphate and, very good, renal stones, calcium phosphate stones, right? Okay, good. Abdominal pain, then polyuria, then the next one is psychosis, then can anyone tell me the fourth one? The fourth one, what is the fourth sign symptom or the symptom of hypercalcemia? Very good. Bone pain. Okay. Abdominal pain, bone pain, polyuria, psychosis, meaning that we usually try to say this by groans, bones, tones, and psychiatric overtones. These are the four symptoms of hypercalcemia, especially if patients will suffer from abdominal pain because of having stones. Patients will complain of having a history of multiple visits to the washroom due to excessive micturition. Patients will have sign symptoms of mild depression, and there will be bone pain. These are the sign symptoms of hypercalcemia. Now, let's talk about, this is the pathology. Let's talk about the normal physiology of how parathyroid will increase your calcium level. Now, parathyroid gland will increase your calcium level by three mechanisms. Number one is, if we talk about the parathyroid glands, then we know that if this is the thyroid, then the parathyroid is basically located in these four regions, yes or no? There are four parathyroid glands, or two pairs of parathyroid glands, from where the parathyroid will get released. Now, the reason why they will get released is if the calcium is low, or if the phosphate is high. Can anyone tell me a very easy cause of hyperphosphatemia? Why is phosphate increased in a patient all of a sudden? Is it due to, let's say, renal failure? Yes or no? Or CKD? Very good. Okay, renal failure or CKD, phosphate could increase. So that's that. So low amount of calcium or high amount of phosphate will stimulate the parathyroid glands. The parathyroid glands will then release the parathyroid hormone. They will release the parathyroid hormone. After the parathyroid hormones are released, what they do is that they travel in the blood and they go to different regions. Number one, the parathyroid will go to the kidneys. Yes, the parathyroid, they will go to the kidneys. And especially when they go to the kidney, what they will do is that they will go to the proximal convoluted tubule, the portions of the proximal convoluted tubule of the kidney, and they will activate a very high yield enzyme, which we call as 1-alpha hydroxylase. Okay, so they will activate 1-alpha hydroxylase. Can anyone tell me what happens after they activate 1-alpha hydroxylase? After they activate 1-alpha hydroxylase, what they will do is that this enzyme, which is activated by the parathyroid, will indirectly activate vitamin D. Very good. Okay, they will activate vitamin D. And when vitamin D is activated, this vitamin D, what it does is it will directly go to the intestines, and they will increase the absorption of calcium. They will increase the absorption of calcium. So indirectly, when parathyroid is increased, can we say that indirectly through the action of 1-alpha hydroxylase, calcium concentration is also increasing by this mechanism? Yes or no? Fast answers, please. Yes. Okay. Good. Very good. So that's that. Next one is parathyroid directly will go to another region. Parathyroid directly will go to another region, and this region is the region of the bones. Yes or no? They will go to the bone, and what they will do is they will create a condition where there is increased amount of calcium resorption. Now, what does this mean, calcium resorption? Calcium resorption basically means that when the parathyroid hormone is released on the bone, it creates an alkaline condition in the bone. It creates, my apologies, it creates an acidic condition in the bones. It creates an acidic condition in the bone. And whenever there is an acidic condition in the bone, the calcium is released from the bone, and this calcium released from the bone under the influence of parathyroid hormone and the creation of the acidic condition is called calcium resorption, meaning that calcium will get released from over here. Now, vice versa, if acidic condition leads to the release of calcium ion, can we assume that alkaline conditions in different parts of the body will result in deposition of calcium ions? Yes or no? Okay. Have you guys understood the question? If you have an acidic condition in the bone, it will lead to the release of calcium ion. Yes or no? But vice versa, if you have alkaline condition in different parts of the body, will you have resorption of calcium or deposition of calcium? Fast answers, please. Will you have deposition or resorption? Deposition. Very good. Okay. Okay, good. Now, I just want to give you guys very quick information over here. What are the lab findings of calcium resorption? The number one lab findings for Usmle step 1, if there's increased amount of calcium resorption beyond the normal physiology. If I say increased amount of, give me 1 second. Okay. Now, if I say increased amount of calcium resorption beyond the physiological measure, does that fall under the pathology? Yes or no? Yes, right? If there's increased calcium resorption beyond the physiological level, then this falls under the pathological release of calcium resorption. Now, how do we figure out whether the patient is suffering from hypercalcemia due to increased calcium resorption? What we do is we check for one thing in the urine. The specimen is in the urine, and the thing that we check in the urine is hydroxy. Can anyone tell me then the next word? Hydroxy what? Hydroxy? Hydroxy, fast answers please. Does anyone know? The answer is hydroxyproline. Okay, we check for increased amount of hydroxyproline in the urine. If there is high amount of hydroxyproline in the urine, what does this indicate? This indicates that there has been excessive release of parathyroid hormone and the patient has excessive amount of calcium resorption. Am I clear? Yes or no? Did everyone understand what I'm trying to say over here? Yes or no? Did everyone understand what I'm trying to say over here? Yes or no? If not, then I will repeat myself. Okay, good. As long as you guys understood. Very good. Now, another thing over here that calcium, my apologies, that parathyroid will do is not only will it increase the calcium level in the blood, it will also decrease the phosphate level in the blood. Parathyroid hormone is also known as phosphate thrashing hormone, meaning that it will decrease the level of phosphate. Now, if anyone asks you how do parathyroid hormone decrease the level of phosphate in the blood? The answer is very simple. The answer is, we know that in the kidneys, you have the proximal convoluted tubule, right? The proximal convoluted tubule, they have a lot of absorption channels, right? Sodium absorption channels. For example, we have sodium bicarbonate channels, sodium phosphate channels, sodium potassium channels. Parathyroid, what they will do is they will go to the proximal convoluted tubule and they will inhibit the sodium phosphate channels. If they inhibit the sodium phosphate channels, then can phosphate be reabsorbed from the proximal convoluted tubule? Yes or no? Fast answers, please. The answer is no. So as a result, high amount of phosphate will be lost by the urine, as simple as that. That's how parathyroid will decrease your phosphate level in the blood. That's that. Now, another thing is, in order for parathyroid to decrease the phosphate level in the blood, does the patient have to have a functioning kidney or a non-functioning kidney? Fast answers, please. Should it be a functioning kidney or a non-functioning kidney? In order for parathyroid to release the phosphate from the kidney has to be a functioning kidney. Very good. The kidney has to be a functioning kidney. It cannot be a non-functioning kidney. If it's a non-functioning kidney, then it does not matter how much parathyroid is being released, it cannot get rid of the phosphate. As a result, you will see a lot of questions where patients will have high parathyroid level, high calcium, and high phosphate. This clinical picture is your typical clinical picture of what? CKD or renal failure. Am I clear? Yes or no? Usually the clinical picture should be something like this: high PTH, high calcium, and low phosphate. Okay, so we have two conditions, A and B. If A is for CKD and renal failure, then this condition, B, is for normal functioning kidney. Yes or no? Is everyone clear? Is everyone clear? Yes or no? No. Okay. Okay, so we have one physician who is not clear. Everyone else is clear. Just give me 1 second. Can we please ask you to keep your mic muted at all times? If you have questions, please use the chat box. Thank you so much. So let me repeat this one more time. Let me repeat this one more time so that it will be clear. There are two types of clinical pictures which you will see with increased parathyroid. There are two types of clinical pictures which you will see with increased parathyroid. One is this: increased PTH, increased calcium, increased phosphate. Another one is increased PTH, increased calcium, and decreased phosphate. This clinical picture is your clinical picture for what? Fast answers, please. This is your clinical picture for? Fast answers, please. This is a clinical picture for which condition? Fast answers, please. RF or CKD. Very good. Okay. And this is your clinical picture for a normal functioning kidney. Normal functioning, not non-functioning, normal functioning kidney. This is normal. Okay, normal kidney. How do you differentiate this easily? All you have to do is you have to look at the serum creatinine level. Okay, if you see that the creatinine level is normal, then you know that this is the clinical picture which you should expect. If the creatinine level is abnormally high, then this indicates that the patient is suffering from CKD, and phosphate is also going to be high. Am I clear? Yes or no? Is everyone clear about this? Okay. Okay, good. What else? Now, there's another thing that I want to talk about is how do parathyroid hormone increase calcium from the bone? One more time. First and foremost, we talked about the fact how parathyroid will create an acidic condition in the bone that will lead to the release of calcium from the bone. Yes or no? Do you guys remember this discussion from 5 minutes ago? Yes? Okay. Now, what happens is, in order for calcium in order for calcium resorption, to take place, a very important cell has to be activated. The name of that cell is osteoclast. Yes or no? The name of the cell is osteoclast. Osteoclast has to be activated. Osteoclast is the bone resorption or the bone resorbing cells. Now, how do the osteoclasts get activated? With the help of parathyroid. This is the question. The question is, how do osteoclasts get activated with the help of parathyroid hormone? Now, osteoclasts, what they have is, just give me 1 second over here. Osteoclasts, what they have is they have a receptor. Osteoclasts, they have a receptor called RANK. Have you guys heard about this receptor? Yes or no? Have you guys heard of the RANK receptor? Yes, very good. RANK, what does this stand for? RANK? RANK stands for receptor activator of nuclear kappa beta ligand. So you do not have to remember the whole abbreviation of RANK. All you have to do is you have to remember the name, that is RANK receptor. So osteoclasts, they have a RANK receptor. Once you activate the RANK receptor on the osteoclasts get activated. They're like scissors. So they go to the bone, right? They go to the bone and they perform their action over here. That leads to the release of calcium. Okay, that leads to the release of calcium. Osteoclasts, they also create an acidic condition that leads to the release of more calcium. And once again, they are activated with the help of parathyroid. Now, parathyroid directly does not increase, or it does not directly activate the RANK. What they do is parathyroid indirectly activates. They will indirectly activate the osteoclast. And this is our last discussion before we begin with the first stage. That is, parathyroid will first activate the osteoblast. Okay, and the osteoblast, once they're activated by the parathyroid, will activate RANK-L. RANK-L. RANK is receptor activator of nuclear kappa. RANK-L is receptor activator of nuclear kappa beta ligand. Once parathyroid activates osteoblast and osteoblast expresses increased amount of RANK-L, this RANK-L will bind with the RANK in osteoclast to activate the osteoclast. Are we clear? Yes or no? Everyone, are we clear about this? Yes? Okay, good. Now, quick questions, quick answers. What is the source of parathyroid hormone? Fast answers, please. What is the source of the parathyroid? Quick recapitulation. Let's do a quick recapitulation of parathyroid of what we have studied till now. Quick recapitulation. The source is chief cells of the parathyroid. Very good. What is the most common cause of hypoparathyroidism? Hypoparathyroidism. The most common cause of hypoparathyroidism is thyroid surgery. Very good. Very good. What is the most common cause of hyperparathyroidism? Adenoma. Very good. Whenever a patient is suffering from adenoma, what pathology should we think about for Usmle step 1, especially, and also for US and all men? Very good. Multiple endocrine neoplasia, type 1, type 2A. Very good. Next question is, parathyroid will increase which electrolyte in the blood? Calcium. Very good. Now, parathyroid will increase calcium from 2 regions. Number 1 is they will go to the kidney and they will activate which enzyme? Fast answers, please. They will activate which enzyme in the proximal convoluted tubule? Very good, 1-alpha hydroxylase. Once they activate 1-alpha hydroxylase, which active form of which vitamin is activated? Vitamin D. Vitamin D will go to which region and increase the calcium level? GIT, very good. Intestines, okay. Okay, good. Next one is they will increase the calcium resorption from the bones by which method? They will increase indirectly, very good. Indirectly by first activating osteoblast, then osteoblast will express rank L. Rank L will bind with rank, and they will activate osteoclast. Osteoclast will increase the acidic concentration of the bones, and they will lead to increased calcium release. Now, how do we understand a patient is going through excessive calcium resorption? How do we understand that the patient is undergoing excessive calcium resorption? Last answers, please. By looking at the urine, hydroxyproline, yes or no? Hydroxyproline in the urine, very good. Okay, good. Can you explain the indirect pathway again? Yes, of course. In the indirect pathway is very simple. The parathyroid will directly activate osteoblast. Osteoblast will express rank L. Rank L will bind with rank because osteoclasts have rank and osteoblasts have rank L. Once there is a binding of rank L and rank, this activates the osteoclast, and then osteoclast will cause bone resorption. As simple as that. Are we clear? Yes or no? Okay. One last piece of information before we go to first aid, that is, in the kidneys, the parathyroid will work in two locations. Number one is the most important one, that is proximal convoluted tubule. Number two is they will also work a little bit in the distal convoluted tubule. In the distal convoluted tubule, do we have calcium exchangers? Yes or no? Is calcium reabsorbed from the distal convoluted tubule? Yes? Yes or no? The answer is yes, meaning that the parathyroid will go and work in the distal convoluted tubule. Do you guys remember how in the distal convoluted tubule, we have the mechanism of action of the thiazide diuretics? Yes or no? We know that furosemide works in the loop of Henle and thiazide works in the distal convoluted tubule. How many of us are aware of this information? How many of us are aware that furosemide is a loop diuretic which works in the loop of Henle, especially they inhibit the sodium-potassium 2 chloride channels. And thiazide diuretics, they inhibit sodium-calcium channels. And the mechanism of action of thiazide is something we will talk later. But are we aware that calcium reabsorption takes place in the distal convoluted tubule? Yes or no? The answer is yes. So they will increase the activity of calcium reabsorption from the distal convoluted tubule. Okay, is everyone clear about all the informations before I begin the parathyroid lecture over here? Is everyone clear about this? Oh. So please keep your red pen or red cursor ready because we will be identifying the questions of the step one. Before we do this, let's talk about the source. Number one question is the source of parathyroid release. That is the chief cell. This is high yield. Next one is what are the functions? They increase the free calcium level in the blood. We just talked about this. They increase calcium and phosphate absorption from the GIT. This should be increased calcium absorption and decreasing phosphate absorption. Okay, increased calcium absorption and decreasing phosphate absorption. Next one is that they will increase calcium release and also the release of phosphate from the bone, and the phosphate will basically get lost through the kidneys once again. Next one is calcium reabsorption from the distal convoluted tubule and decreased phosphate reabsorption in the proximal convoluted tubule. We talked about all of this. Next one is they will activate 125 dihydroxy D3 by activating 1-alpha hydroxylase. Especially in the proximal convoluted tube. Are we clear about all the functions of the parathyroid? Yes or no? Okay. Next one is the mechanism. They increase the serum calcium level and decrease the serum phosphate level. They increase urinary phosphate and increase urinary CNP and increase urine hydroxyproline. Please write this down. They increase urine hydroxyproline. This is the mechanism we just talked about, how they activate the osteoclasts. This is exceptionally high yield for step 1. Please put your star marks over here. This you guys will be tested on this. PTH is also known as phosphate crashing hormone. I talked about this already. This is something I'll talk about in 1 minute. Okay, this is something I'll talk about in 1 minute. Before I do this, let's talk about the regulation. Regulation is how and why is the parathyroid secreted. It's secreted under the influence of low calcium level or high phosphate level. Sometimes the magnesium level also affects this, because whenever magnesium is low, always remember this, whenever magnesium is low, calcium is also low. Calcium and magnesium is connected. Hypomagnesemia is associated with hypocalcemia. So that's why decreased magnesium level, especially very low decrease of magnesium level, will decrease parathyroid secretion, and low magnesium level will increase your parathyroid. This is a little bit confusing for your step 1. So you do not have to remember this. They do not test you on this piece of information. So all you have to do is remember that low magnesium level will increase parathyroid, because low magnesium is associated with low calcium. Okay, so that's that. How do they increase the CAMP in the urine? I'll come to this in 1 second. Before I do that, let's talk about the diagram that we have here. As you can see, low calcium is stimulating the parathyroid gland to release the parathyroid. They work in the kidneys, bone, and intestines, as I have just talked about. Next one is another high yield pathology for USMLE step 1. Another high yield pathology for USMLE step 1 is, how many of us are aware that about paraneoplastic conditions? What do you mean by paraneoplastic condition? Can anyone explain paraneoplastic condition? What does this mean? Paraneoplasm. Can anyone explain what is paraneoplasm? Symptoms with cancer, very good. Okay, so that's a pretty close explanation. Meaning the word paraneoplasm basically means periphery and neoplasm. What does this mean? This means that there is a primary tumor and there is a distant or a separate sign symptom for that tumor. Especially when it comes to parathyroid, we have a very high yield neoplasm, very high yield primary neoplasm, which is the squamous cell carcinoma of lungs. If a patient is suffering from a squamous cell carcinoma of the lungs, they will have excessive release of a peptide or a protein, which is called PTHRP, parathyroid hormone related peptide. Now, is PTHRP the same as PTH? The answer is no. PTHRP is not the same as PTH, meaning that when a patient is suffering from squamous cell carcinoma of the lungs, they will have increased secretion of parathyroid related peptide. This parathyroid related peptide will work exactly like parathyroid hormone by increasing the calcium level and decreasing the phosphate level, but they will also decrease the level of parathyroid. Are we clear? Yes or no? Is everyone clear about this? So if you see a clinical finding or a laboratory finding of something which looks like this, increased calcium, decreased phosphate, and decreased parathyroid, which diagnosis shall you think about, or what should you think about when you see something like this? The answer is, well, what is the answer for this sort of laboratory findings? Very good, SCC. SCC of the lungs. Okay. So one more time. Just give me 1 second. The three things that we will see is high calcium, low phosphate, high PTH, high calcium, high phosphate, high PTH. Another one is high calcium, low phosphate, and low PTH. Now, what are the reasons for these three types of condition? Fast answers, please. What is the reason for this sort of a clinical picture? The answer is high calcium, low phosphate, high PTH. The answer is this normal or abnormal? Fast answers, please. Normal, very good. Okay. What is the reason for this sort of a clinical picture or a laboratory finding? Fast answers, please. This is CKD. Very good. What is the clinical reason for this sort of a laboratory finding? The answer is SCC. Very good. Are we clear? Yes or no? Everyone, are we clear about this? Okay, good. Okay, next question is how and why does the urinary CAMP increase? The urinary CAMP increases with parathyroid because in order to activate the acidic condition of the acidic condition of the bone, the parathyroid, what they do is they work by a very high yield mechanism. That is, they work by the CAMP mechanism. Parathyroid, they work by the CAMP mechanism. That is, they activate the adenylate cyclase. Adenylate cyclase activate the cyclic adenosine monophosphate. And whenever cyclic adenosine monophosphate is increased, the acidic condition in the bone also increases, which leads to increased release of even more CAMP and increased release of hydroxyproline. So these two appear in the urine, and these two indicate increased calcium resorption. Are we clear? Yes or no? Okay. Okay. So that's it. So we have discussed quite a little bit about parathyroid because parathyroid is exceptionally high yield for Usmle step 1. And that is why we took a little bit of time to talk about parathyroid, because in order for you to understand this text, you have to understand what's happening behind the text. So that's that. So can we move on to the next one right now? Can we move on to calcium homeostasis? Yes or no? Can we move on to calcium homeostasis? Can we move on to the next page? Does anyone have any more questions from over here? If you have, now is the best time to ask. You guys have any questions about parathyroid, hormone regulation function? Does anyone have any question? Yes or no? No. Okay. Clear. Very good. Okay, I'm glad. Thank you so much. Now, calcium homeostasis. Calcium homeostasis is basically how does calcium exist in your blood? Always remember this, calcium exists in your blood either in free form or in bound form. If it's bound, then the calcium is inactive. If it's free, then the calcium is active. Okay, as simple as that. So if it's bound, it's basically bound to albumin, which is 40%, and it could also be bound to different sorts of anions. For example, it could be calcium phosphate or different sorts of anions, and that amount is 15%. And the free calcium is actually 45%. It's an active form. Okay, so that's that. This is high yield for step 1. You have to know the three ways how calcium exists in your blood, okay? So bound and not bound. Not bound is 45, bound is 55. Out of those 55%, it's bound 40% to albumin and 15% to Ni. So that's that. Increase pH, albumin will bind more, and you will have, so basically this is what I'm trying to say. When you have low pH, this means that calcium level will increase, right? Meaning that more calcium will get released. If there is high pH, calcium levels will drop. Why? Because they will go and they will go and bind to the different sorts of tissues that have high alkaline conditions. So that's it. So do you guys remember how I talked about the fact of how parathyroid will create an acidic condition? Yes or no? Do you guys remember how I talked about parathyroid will create an acidic condition? Yes or no? Fast answers, please. Yes, okay. So whenever parathyroid creates an acidic condition, this leads to the release of more ionized calcium. If there's release of more ionized calcium and the calcium level in the blood increases, should the parathyroid be increased or decreased? The answer is, once calcium level increases, the parathyroid shall decrease back to its normal form. No, it should decrease. It should not increase because acidic condition will lead to more release of calcium. If calcium is released more, then parathyroid shall decrease. Yes or no? Fast answers, please. Yes? Okay, good. Okay, and vice versa. If there is increased amount of an alkaline condition in a bone, in any tissue, then calcium will get deposited, or it will either bind itself to more albumin and calcium level will fall, and vice versa, parathyroid will increase. This is the homeostasis. Are we clear? Yes or no? Okay. For example, have we heard about calcifications of different sorts of tissues in the body? Yes or no? For example, there could be calcifications of the pancreas. There could be calcifications of the stomach, right? Why do different tissues of the body undergo calcification? Always remember this, different tissues of the bodies undergo calcification because the alkaline condition of the tissues increases, meaning that the pH of the tissue, they increase. Once pH of any tissue increases, there's increased calcium deposition in the tissues. Are we clear? Yes or no? Okay. Is everyone clear about this? Does anyone have any questions? Okay, now. Next one is calcitonin. What is calcitonin? Calcitonin is another type of hormone that is secreted by the parafollicular cells. The number one high yield pathology associated with high amount of calcitonin is medullary thyroid cancer. Medullary thyroid cancer is basically the carcinoma of parafollicular cells of the thyroid. This leads to excessive release of calcitonin. This excessive calcitonin will cause increased serum calcium level, and my apologies. This excessive calcitonin will lead to low calcium level, and basically that's that. Meaning that if calcium level is exceptionally high, they go and they stimulate the parafollicular cells. The parafollicular cells will then release calcitonin, and calcitonin will decrease the calcium level. As simple as that. So basically, calcitonin is the opposite of parathyroid. If parathyroid increases calcium, then calcitonin will decrease calcium. Are we clear? Yes or no? Everyone? Are we clear about this? Okay. So a patient suffering from medullary thyroid carcinoma, should they be suffering from hypercalcemia or hypocalcemia? The answer is hyper or hypo? Hypo. Very good. Hypo. But, okay, hypo, but which one has more power, calcitonin or parathyroid? Which one is more potent? The answer is parathyroid. Very good. So if a patient is suffering from medullary thyroid carcinoma and parathyroid adenoma, or parathyroid tumor. The clinical picture should be a clinical picture of hypercalcemia or hypocalcemia. Fast answers, please. Hypercalcemia, very good. So in a patient of MEN 2A, where we see medullary thyroid carcinoma and parathyroid adenoma, do we will expect to see hypercalcemia, as simple as that. That's what I'm trying to say over here. Okay. Are we clear? Can I move on to glucagon? Yes or no? Can I move on to glucagon? Oh, glucagon. Okay. What is glucagon? Glucagon is another hormone that is secreted by the alpha cells of the pancreas. The function of glucagon is very simple. It's released to increase your glucose level. Right? In a clinical setting, do we use glucagon? The answer is yes or no. Do we use glucagon in a clinical setting? The answer is yes. How and when? Can anyone tell me when and how we use glucagon in a clinical setting? Why we use glucagon in a clinical setting? Can anyone tell me over here very quickly, why do we use glucagon in a clinical setting? No. Okay. Yes or no? Fast answers, please. Yes or no? Okay, so we have one student who wrote hypoglycemia. The answer is absolutely correct. We use glucagon in hypoglycemia. Can you tell me when, Dr. Ethar? When do we use hypoglycemia? When do we use glucagon for hypoglycemia? In starvation? No. Okay, that's not the correct answer. The answer is, if you have a patient who's suffering from hypoglycemia, what do we do? If the patient is conscious, in a conscious patient, what do we do? We give them sugar-containing food, yes or no? Juice, candies, chocolates, yes? Fruits, okay, good. If the patient is unconscious, then what do we do? If the patient is unconscious, we do two things. Either we go for IV or IM. IV glucose. And in severe hypoglycemia, we would give IM, intramuscular glucagon. Yes or no? Okay, so this is the clinical importance of glucagon. That's how, and that's why we give glucagon in a clinical setting, number one. Number two is, can there be a tumor of the alpha cells of the pancreas? Yes or no? The answer is yes. If there is, then we call this glucagonoma. Yes, we call this glucagonoma. In glucagonoma, we will see hyperglycemia, and we will see another very high yield finding. Let me just show you the finding over here, glucagonoma. Another name of the glucagonoma skin rash is necrolytic migratory erythema, something which will look like this. Okay, very characteristic. You see a little bit of formations of different sorts of bullas, and the bullas will rupture, leading to a clinical picture, which looks very similar to something like this, or this, or this. This is necrolytic migratory erythema. It's called migratory because the skin rash will migrate from one part of the body to another part of the body. So that's that. This is exceptionally important for USMLE step 1. So that's that. Are we clear? Yes or no about the two conditions, the two clinical conditions of glucagon? One is IM glucagon. We use this for hypoglycemia. Another one is glucagonoma, that we see hyperglycemia along with necrolytic migratory erythema or glucagonoma skin rash. Another thing is, if you see a patient of glucagonoma, which type of men will you think about? Men 1, 2A, or 2B? Which one? Men 1. Very good. Because this is a pancreatic neoplasm. Okay. Are we clear? Yes or no? This is a pancreatic neoplasm. So the functions of glucagon is very simple. If you have glycogenolysis, what does this mean? Glycogenolysis. Glycogenolysis is the process of breaking down glycogen. Will glucose increase or decrease? Fast answers, please. If we have the process of glycogenolysis, glucose will increase. Very good. Next one, gluconeogenesis, meaning that we use different substrates to create glucose, meaning we can use lipids or amino acids. If we do that, glucose, will it increase or will it decrease? Fast answers, please. Well, of course, the glucose will increase. Very good. Next one is lipolysis. If we have excessive fat breakdown, do we have more substrates for gluconeogenesis? Yes or no? The answer is, fast answer please, yes. Once we do we have high glucose? Once again, yes or no? The answer is yes, very simple. And they can also cause a little bit of ketogenesis. So that's it. It elevates the blood sugar levels to maintain homeostasis when bloodstream glucose levels fall too low, for example, in a fasting state. So that's that. And regulation is it's secreted in response to hypoglycemia. We all know this. And hormones such as insulin, amylin, somatostatin, and hyperglycemia will oppose that. That is, they will decrease glucagon secretion. Okay, very simple. Have we understood glucagon? Yes or no? Clear? Okay, good. Now, let's talk about insulin. Is everyone understanding the lecture for today? Yes or no? I hope the lecture is not too complicated. I'm trying to give you as much information as possible regarding the different sorts of questions that you will face in your step 1 exam. Okay. Now, okay, good. Let's move on to the next one, that is insulin. Insulin is exceptionally high yield for step 1, 2. So we'll talk about insulin. Before we talk about insulin, do you guys want to take a small 5-minute break so that you can clear your minds a little bit? Yes or no? Yes? Okay. Okay. All right. Very well. Let's take a short 5-minute break. After that, we will come back and we will talk about insulin, and then we will talk about this exceptionally high yield table. Okay. So it's 9:43 as of right now. Let's start the class once again at 9:50 a.m. Are we clear? Yes or no? Everyone? Okay, good. So let's take a break for 5 minutes. After that, let's come back and let's finish physiology for today. And then tomorrow we can begin with endocrine pathology. Okay, so thank you so much. Let's take 5 minutes. Okay, is everyone back from their break? Can you guys hear my voice? Yes or no? Okay, good. Is everyone back from their break? We see Dr. Itar is back, Dr. S is back. Thank you so much, Dr. S, for your questions. I will answer the questions after the end of the lecture. Thank you so much. All the other students, are you guys back from your break? Okay, good. Can we begin with the discussion of insulin? Now, so let's talk about insulin over here very quickly. What is insulin? Okay. What is insulin? Insulin is basically a hormone that is secreted by the beta cells of pancreas. Yes or no? They are secreted by the beta cells of the pancreas. Why are they secreted? They are secreted in response to increased amount of glucose. When the glucose level in your body increases, insulin secretion increases. As simple as that. We'll talk about the pathology in 1 second. Insulin works to decrease your glucose level. Yes or no? Increased amount of glucose leads to increased release of insulin. This increased insulin works to decrease your glucose level. How? Can anyone tell me how? The answer is by increasing glucose uptake. Yes or no? Are you guys aware of this small piece of information? Yes or no? I'm pretty sure you guys are aware of this information. Yes or no? Okay, good. Very good. Now, what I do want to talk about is insulin, how does insulin affect your glucose level? Meaning that how does insulin increase glucose uptake? Now, in insulin, what it does is insulin is responsible for the creation of a very high yield channel called glucose transporting channel, especially GLUT4. We'll talk about this in 1 second. Before I do this, let's talk about how insulin is secreted. Is everyone ready? Yes or no? For the discussion of how insulin is secreted? Yes? Okay, good. Now, this is a microscopic view of pancreatic tissue. Okay. This is a microscopic view of a pancreatic tissue, especially let's say that we have taken this tissue from the tail of the pancreas, and we know that the tail of the pancreas is exceptionally high in insulin, right? The tail of the pancreas, they have a lot of different sorts of vesicles, which contains insulin. Okay, now, how is this insulin released from the pancreatic tissue into the blood? That is the question. Now, this is very simple, and I need you guys to have your utmost attention right now. Pancreatic tissues over here, they have a channel. They have a channel over here. This channel is called GLUT2, glucose transporting 2 channels. Glucose transporting 2 channels are created by insulin themselves. They're created by insulin themselves. Insulin works in a different part of the body to create the glucose transporting 2 channels. This glucose transporting 2 channels, what they do is that they increase the glucose uptake. They increase the glucose uptake, the glucose they increase, and they enter into the pancreatic tissue. Once they enter into the pancreatic tissue, the glucose inside the pancreas will undergo glycolysis. Whenever glucose is broken down, what do we get? Do we get energy from the breakdown of glucose? Yes or no? Because we know that the glucose is broken down by the process of glycolysis. After that, we have a very potent product, which I will not talk about right now, but they enter into the TCA cycle. Yes or no? They enter into the TCA cycle. Once they enter into the TCA cycle, we have the production of a substrate that allows the activation of the HMP pathway. And all in all, what I'm trying to say over here is that the breakdown of glucose leads to the formation of what? Can anyone tell me what do we get from glucose? Past answers, please. Do we get ATP? Thank you so much, ATP. Glycolysis, TCA, HMP, and then all in all, when we break down glucose, we get ATP. What happens when we get ATP? ATP, what it does is they activate another channel over here. Okay, ATP, what it does is they activate another channel. This channel is a potassium channel. This is ATP sensitive potassium channel. This is not a sodium potassium channel. This is an ATP sensitive potassium channel. So ATP will directly activate this channel, which will lead to excessive efflux or outflux or release of potassium from inside the cell to outside the cell. Whenever potassium leaves, what happens over here is we get depolarization in the cell. Yes or no? Whenever potassium leaves, we get cellular depolarization. Is it clear or not? Yes or no? Are we clear up to this point? Is everyone clear up to this point? Yes or no? Okay, good. So the release of potassium leads to depolarization. This depolarization, all in all, activates another channel. And this is the last channel. This is voltage gated. This is voltage gated calcium channel. So whenever we have depolarization inside the pancreatic tissue due to the release of potassium, calcium enters into the tissue. And whenever intracellular calcium level is high, we know that the vesicles, they start fusing with the periphery. And whenever we have peripheral fusion of the vesicles, we have the release of the hormone into the bloodstream. Yes or no? We have the release of the hormone into the bloodstream. Are we clear about this? Yes or no? Okay, so one more time, how is insulin released from the pancreatic tissue? First step, step number one, glucose will enter. Okay, glucose will enter into the cell with the help of the GLUT2. Whenever GLUT2 works, glucose enters inside the cell. Whatever glucose does, it undergoes glycolysis. ATP is released. ATP, what it does is ATP will lead to increased closure of the potassium channel. The potassium will stop going out. As a result, intracellular potassium will increase. As intracellular potassium increases, there is cellular depolarization. This depolarization leads to increased amount of calcium entry. Calcium will enter, and this will cause vesicular fusion, leading to excessive release of insulin into the blood. Are we clear? Yes or no? Does anyone have any question? Shall I repeat myself one more time? No. Okay. Can anyone explain this mechanism before I start with another mechanism? Can anyone explain this? Please write me in the chat box if you're confident that you can explain this step by step. Anyone? Okay. All right, very good. Okay, so we have Dr. Salman. Thank you so much for helping us out. Do you mind unmuting yourself and explaining us the mechanism of insulin release?
Yes, sir. Sir, whenever the concentration of glucose in blood increases, it enters into the beta cells by the means of the GLUT2, and it undergoes glycolysis and produces ATP, due to which the ATP increases in cell, and they activate the ATP-dependent potassium channels, due to which potassium leaves the cell because it is high in cell.
No, they do not activate, they inactivate. They close the potassium channel. They close the potassium channel. Okay, and this prevents the release of potassium, leading to increased potassium that leads to depolarization. Okay,
depolarization. And then calcium channels open, voltage get it because of repolarization, and calcium enters into cell, and this led to the release of the exocytosis of the vesicles.
Very good. Okay. Are we clear? Okay. Did I mistakenly mention that ATP will open the potassium channels? Yes or no? My apologies if I was mistaken before. Okay, my apologies. ATP will close the potassium channel, not open. Okay, please keep that in mind. They will not open the potassium because once potassium starts leaving, there will be hyperpolarization, not depolarization. Okay, are we clear? Once potassium leaves, there will be excessive hyperpolarization, not depolarization. So closure of the potassium channel leads to increased potassium level inside the cell, leading to depolarization that will make the calcium enter. Now, the next mechanism that I want to talk about is how and why does GLUT2 increase? Now, insulin will increase GLUT4 and GLUT2. Now, insulin, what it does is once it's released, insulin will work in different parts of the body. Especially, insulin will work by a very high yield mechanism. Let me talk about this mechanism very quickly over here. Insulin works by tyrosine kinase mechanism. Tyrosine kinase mechanism. Insulin, what it does is it phosphorylates tyrosine, meaning that it adds a phosphate group to the tyrosine. And when we have tyrosine phosphorylation, we have the activation of two things over here. Number one is phosphatidyl inositol 3 kinase pathway. Another one is RAS-MAP kinase. Okay. RAS-MAP kinase. Now, let me repeat this one more time. Okay, let me repeat this one more time. Just give me 1 second over here. Okay. Now, let's say that this is a cell. Okay. Over here, you have the insulin receptor. Always keep in mind, excuse me, that the insulin receptor have 2 alphas and 2 beta subunits. Insulin comes and it binds to the alpha subunit, and the beta subunit phosphorylates the tyrosine. There is tyrosine phosphorylation. Whenever tyrosine is phosphorylated, there is activation of 2 pathways. Number one is phosphatidyl inositol 3 kinase pathway. Another one is there is activation of the RAS-MAP kinase pathway. Now, always remember this, whenever you activate RAS-MAP kinase, there is excessive or there is increased cellular growth and there is increased DNA synthesis. Now, my next question is, if RAS-MAP kinase is functioning normally, then we have normal cellular growth, right? Which we say as hyperplasia. If RAS-MAP kinase is working abnormally, or if there's an abnormal increase in the RAS-MAP pathway, can anyone tell me what condition or what is the name of the disease when we have excessive activation of the RAS-MAP kinase? Fast answers, please. Normal activity leads to hyperplasia. So abnormal activity would lead to what? Fast answers, please. Fast answers, please. What would abnormal activity of the RAS-MAP kinase lead to? If there's excessive activation of the RAS-MAP, then what do we get? Do we get anaplasia? Yes or no? Do we get anaplasia? Meaning that carcinomas or different cancers in the body, the reason why we can get carcinomas in different parts of the body is due to excessive activation of the RAS-MAP kinase, yes or no? Yes? Do you guys understand what I'm trying to say over here? If you haven't, then I will repeat myself. Can I get a yes or a no in the chat box, please? Okay. So what I'm trying to say over here is that insulin is an anabolic hormone. Insulin is an anabolic hormone. Now, the anabolism of insulin depends on If anyone asks you, or if there's a step one question, what is the anabolic pathway of insulin? The anabolic pathway of insulin is the RAS-MAP pathway. It's a very, very detailed pathway. The details of this pathway is not important for step one, but just try to remember that when you activate RAS-MAP, you have cellular growth and increased DNA synthesis. And excessive activation of RAS-MAP would lead to, one more time, excessive activation of RAS-MAP would lead to what? Fast answers, please. Excessive activation of RAS-MAP would lead to CA, meaning carcinomas. Okay, anaplasias. Very good. Now let's talk about the phosphatidylinositol 3 kinase pathway. When we have activation of the PI3K, we have excessive, we have increased formation of GLUT4. And this GLUT4 is released into the blood. And when it is released into the blood, the GLUT4 goes to different parts of the body. Especially it goes to two major locations. Number one is it goes to the skeletal muscle. And number two, it goes to the adipose tissue. Can anyone tell me what happens when GLUT4 goes to the skeletal muscle and into the adipose tissue? Do we have increased glucose uptake or decreased glucose uptake? Fast answers, please. Increased uptake. As a result, what happens? Do we get hypoglycemia or hyperglycemia? We get hypoglycemia, or the glucose level in the blood normalizes. Yes or no? For example, let's say you guys have a high carbohydrate meal. What would happen to the glucose level in your blood? Will it be increased or will it be decreased? Fast answers, please. Increase, very good. Once we have increased glucose, what would happen to the insulin level? Okay, let's talk about this one more time. Okay, let's say this is, okay. Now, this is glucose. We have a high carbohydrate meal, the glucose goes, right? From the intestines, it's absorbed into the blood. Now this glucose will indirectly do what? Glucose will enter the GLUT2 in the pancreatic beta cell and lead to the release of insulin by the mechanism of blocking the ATP sensitive potassium channels, right? The discussion that we had. And then after that, insulin will get released and insulin will activate PI3K and RAS-MAP. And PI3K would lead to increased formation of GLUT4, and RAS-MAP will cause increased anabolism. That's why we have cellular growth after we have carbohydrate. And this GLUT4 will increase the glucose uptake in the skeletal muscle and adipose tissue. And that's how the glucose level over here, after we had a carbohydrate meal, is normalized. Normal glucose. Is everyone clear about this mechanism? Okay, are we clear? Yes or no? Okay. Now, next discussion is, do you guys remember how I told you that the major organ in our body is obviously the brain? Yes or no? Do you guys remember this from yesterday's discussion? The major organ is the brain, meaning that if the body undergoes stress or any other dysfunctional abnormality, then the number one response of the body is to save the brain. And the brain is highly, highly dependent on what? Glucose, oxygen. Yes or no? Do you think that the brain tissues, the tissues of the brain, will wait for insulin to come and create GLUT4? No. If the brain had to wait for insulin to come and save it, then we would not have survived a lot of different types of stressful situations, right? because whenever we undergo stress, then the brain metabolism increases and they use a lot of glucose from our body. So this must mean that brain is not dependent on insulin. It is not dependent on insulin. So if I have to talk about this, then should there be another sort of glucose absorption channel or a glucose transporting channel? The answer is yes. What is the name of that channel? That channel is called GLUT1. Are we clear? GLUT1 is an insulin independent channel. It does not depend on insulin. There are three other organs tissues that uses GLUT1. The way that you can remember this is very easy. All you have to do is remember the mnemonic RBC. RBCs, they stand for R for RBC, that is red blood cell, B for brain, C for cornea. That's all you need to know. We also have another one that is placenta, but RBC, if you can remember, red blood cell, brain, and cornea by RBC, then that's all you need to know. Are we clear about this? Yes or no? Next one is GLUT2. Where can we find GLUT2? Can anyone tell me? We just talked about this. Number one, where do we find GLUT2 the most? Fast answers, please. Where do we find GLUT2 the most? GLUT2, pancreas, very good, pancreas. Especially the beta cells of the pancreas. Okay. Where else? We can get GLUT2 in the liver. We can get a little bit of we can find a little bit of GLUT2 in the kidney, but the one location which you cannot afford to forget is the pancreatic beta cell. This is exceptionally high yield. Okay. Next one is GLUT4. Where do we get GLUT4? Fast answers, please. Number one, skeletal muscle. And where? Skeletal muscle and adipose tissue. Very good. Very good. Okay. Now, we have two other low yield GLUT channels. I'll still talk about them. Now, one is GLUT5. Where do we get GLUT5? GLUT5 is there in two locations. Number one, it's there in the GIT for the absorption of fructose, not glucose. And it's present in spermatocytes because sperm is highly enriched with fructose. So that's that. So it's there in the spermatocytes and it's present in the GI tract. So we have GLUT1, 2, 4, and 5. We're missing out another one that is GLUT3. This is not very high yield, but still GLUT3, we get them in two places. You can remember this by BP. BP is brain and placenta. As simple as that. Are we clear? Yes or no? Okay. Quick questions, quick answers. GLUT1, where do we get GLUT1? Where do we get GLUT1? Fast answers, please. RBCs, very good. Where do we get GLUT2? Very good. Where do we get GLUT4? Where do we get GLUT4? Adipose tissues and skeletal muscle. Very good. Where do we get GLUT5? Where do we get GLUT5? Very good. Where do we get GLUT3? Where do we get GLUT3? BP. Okay, very good. Next one. Okay, then the next thing I want to talk about before I begin the text from first aid is two things. I want to talk about the differential diagnosis of hyperinsulinemia. Okay, hyperinsulinemia. This is not the discussion of normal physiology. This is obviously the discussion of pathology. Okay. There are two conditions where we can get patients of hyperinsulinemia. Number one, is if the patient is suffering from insulinoma. Number two, if the patient is abusing insulin or has been prescribed insulin by someone else. Isn't that a possibility? Yes or no? Have you guys heard of factitious disorder? Do you guys know what a factitious disorder is? It's a psychological psychiatric condition where patients usually undergo or they have a factitious disorder on themselves or factitious disorder on other, meaning that they would like to get medical attention by creating a false medical picture. For example, the false medical picture about abusing insulin is hypoglycemia. Patients will come with hypoglycemia and they will obviously get treated, but these patients, they will come again and again with hypoglycemia, or they can come with a family member, especially if it's a child or an elderly patient. They will inject the child or the elderly patient with insulin, creating a hypoglycemic condition so that they can get false medical attention, as simple as that. So how do you differentiate insulinoma from an insulin abuse? The easiest way that you can differentiate these two conditions is by looking at two things. Number one is insulin level and C-peptide. Very good. And C-peptide. Always remember this, insulin, when it is secreted from the beta cell of the pancreas, insulin is not secreted by itself. Insulin is secreted with C-peptide. So physiological release of insulin or insulinoma or any other reason why insulin level can increase physiologically, or insulinoma or any other reason for which there could be increased release of insulin from the beta cell, it will be released with the presence of C-peptide. So if a patient has high insulin and high C-peptide, this means that the patient has insulinoma. If the patient is abusing insulin, what should happen to the C-peptide level? It should be normal or low, and insulin shall be high. Okay. And insulin shall be high. Okay. Now, there's another clinical condition where patients, instead of abusing insulin, they abuse sulfonylurea. In this case, sulfonylurea is a type of drug that will increase the release of insulin. So in a circumstance of abusing sulfonylurea, patients can get high insulin and high C-peptide. So it is unrelated to insulin abuse or insulinoma, but it is related to excessive abuse of sulfonylurea. In this case, how do we differentiate sulfonylurea abuse from insulin abuse from an insulinoma? All we have to do is, after we see high insulin and high C-peptide, either number one, we can do abdominal imaging to exclude insulinoma. If in abdominal imaging, insulinoma is not there, the next thing that we can do is we can do a psych evaluation. Are we clear? Yes or no? Everyone, are we clear about this? No. Good. So that's that. Now, let's talk about insulin. Insulin, as you can see from over here, insulin, excuse me, my apologies. Insulin is released with the help of C-peptide. Insulin is bound to C-peptide, and the C-peptides are bound to each other by disulfide bonds. Okay, so that's that. It's released as a pre-pro-insulin, meaning that it's released as a type of insulin which is non-functional, and then only after you break a certain portion of that non-functional insulin, it forms into a functional, somewhat functional insulin that we call it pro-insulin, and that pro-insulin is then released from the pancreatic beta cell by the mechanism of GLUT2 and ATP and potassium and calcium, and then we get insulin and C-peptide release. So that's that. Now, insulin and C-peptide are released in insulinoma and sulfonylurea use. whereas exogenous insulin will lack C-peptide. This is what I talked about a little bit earlier. So that's that. These are your questions about step one. From step one. So that's it. Now, let's talk about the function of insulin. Number one is insulin will bind to the insulin receptor, which is a tyrosine kinase receptor. This is exceptionally high yield. That insulin receptor is a tyrosine kinase receptor. This is exceptionally high yield. You will be tested on this on UWorld, NBME, AMBOSS, and different places. It will induce glucose uptake and also into insulin-dependent tissues, and it will activate gene transcription by RAS-MAP pathway. So that's that. It will activate gene transcription by RAS-MAP pathway. These are some of the anabolic effects of insulin. It will increase glucose uptake, increase glycogen synthesis, sodium retention, protein synthesis. Now, out of all of this, you do not have to remember all the functions of insulin except this one high yield function. Insulin will increase the cellular uptake of potassium and amino acids. So if a patient has excessive administration of insulin, do we expect to have hypokalemia or hyperkalemia? Fast answers, please. Hypokalemia or hyperkalemia? We will get hypokalemia. As simple as that. Now, that's basically what it is. Next one is, okay, before I talk about this, so can we treat a condition of hyperkalemia with insulin? Yes or no? In a patient who is suffering from severe hyperkalemia, we give a couple of things. We give calcium gluconate to protect the heart from life-threatening arrhythmia. We try to make sure we give calcium binding resins so that the potassium can leave through the GI tract. We try to give furosemide to make sure that potassium leaves to the urine. And then if nothing works, then we would like to give insulin and glucose in combination so that the patient doesn't suffer from hypoglycemia. At the same time, insulin can increase the cellular uptake of potassium. So that's that. So this is exceptionally high yield. This is all you have to remember from over here. Now, then you have to remember about the GLUT receptors, which we talked about. There is another receptor called SGLT1 and SGLT2. These are blocked by a very high yield anti-diabetic drugs. There is a canagliflozin, dapagliflozin. These are the type of drugs that will increase the glucose release. So that's that. And that's all we need to know from over here. Let's come back to the regulation. We know that glucose is the major regulator and the stimulus for the release of insulin. Insulin response with oral is very high versus IV because insulin is released when glucose activates incretins. Incretins is a type of protein. It's a glucagon-like peptide, GLP-1. Sometimes we can also block or increase the activity of incretins to increase the release of insulin. We'll talk about incretins in details in anti-diabetic drugs. For now, let's move forward. Another thing is they talked about how glucose will enter the beta cell. It will get glycolyzed, release of more ATP. They will close the potassium channel, depolarize the beta cell, and increase the entry of calcium. We talked about all of these things. And that's all about the discussion of insulin. This is exceptionally high yield. You cannot afford to forget these two diagrams. Okay. Are we clear about insulin? Yes or no? Did everyone understand insulin? Did everyone understand insulin? Yes or no? Okay. Okay. Now, if we have a patient with insulinoma, which type of multiple endocrine neoplasia would you think about? MEN1, MEN2? MEN1. Okay. Very good. Once again, can anyone tell me the three pathologies of MEN1? What are the three pathologies of MEN1? Anyone? Can anyone tell me the three pathologies of MEN1, please? Very good. Pancreatic, parathyroid, pituitary. Yeah. So that's done. Now, are we ready to start talking about adrenal steroids and congenital adrenal hyperplasia? Is everyone ready? Yes. Can I get a yes from everyone else, or do you guys want to take another small break before we talk about adrenal steroids and congenital adrenal hyperplasia? Break or no break? Fast answers, please. Can I get some feedback in the chat box? No. Very good. Let's begin. So I want to begin the discussion of adrenal steroids, and this is exceptionally high yield for step 1 and step 2 CK, and for your clinical practice as a physician in the future. Now, what I want to talk about is I want to talk about how the adrenal cortex produces mineralocorticoids, glucocorticoids, and adrenal androgens. This is the discussion. Mineralocorticoids, glucocorticoids, and adrenal androgens, how are they produced? Now, let's talk about the number one thing over here. First and foremost, mineralocorticoids, glucocorticoids, and adrenal androgens, what is their composition? Are they carbohydrates, are they proteins, or are they steroids or fats? Fast answers, please. Carbohydrate, protein, steroids, or fat. They are steroid. Very good. Very simple. If they are steroid, then what should be the number one substrate for their production? The number one substrate for their production should be, very good, cholesterol, right? So we need cholesterol for the production of mineralocorticoids, glucocorticoids, and adrenal androgens. So let's get this out of the way. So cholesterol is there. Now let's focus on 3 different regions. Just give me 1 second. Okay, so let me draw 3 lines over here. This line is about the 3 locations of the adrenal cortex, meaning that we have the zona glomerulosa, zona fasciculata, and we have the zona verticularis. So let's see what happens over here, step by step. So first and foremost, we have cholesterol. Can anyone tell me where is this cholesterol coming from? This cholesterol is coming from the diet, yes or no? This cholesterol is coming from your food habits and from your diet, okay? So the cholesterol, first step is that the cholesterol is converted to a very high yield sterol containing compound called pregnenolone or pregnenolone. Okay, so however you want to pronounce this, it's all up to you. You can pronounce this as pregnenolone or pregnenolone, but the cholesterol is converted to pregnenolone with the help of a high yield enzyme. This enzyme is called desmolase. Okay, this is the region of zona glomerulosa. This is fasciculata, this is verticularis. Okay, did we understand the first step? Yes or no? Cholesterol is converted to pregnenolone with the help of cholesterol desmolase. Next step. Next step is that the pregnenolone over here will get converted to progesterone. Very simple. Progesterone. It's another sterol containing compound. What is the name of the enzyme? The name of the enzyme that converts pregnenolone to progesterone is 3-beta hydroxysteroid dehydrogenase. 3-beta hydroxysteroid dehydrogenase. Okay, so that's that. I know this sounds a little bit complicated right now, but after the end of our discussion, this will sound much easier, and I'll tell you exactly what you have to do so that you do not forget this in the future. So do not focus on how difficult this is right now. Please focus on understanding on what's happening. So we have cholesterol that's converted to pregnenolone by desmolase. Then pregnenolone is converted to progesterone by 3-beta hydroxysteroid dehydrogenase. After that, progesterone is converted to another sterol containing compound. This compound is called 11-deoxycorticosterol. 11-deoxycorticosterol. The enzyme that is responsible for doing this is high yield, and you have to remember this. You do not have to remember this one. You do not have to remember this one. This is not a problem, but you cannot afford to forget this enzyme, which converts progesterone to 11-deoxycorticosterol. This is 21-hydroxylase. So I'm going to write 21H, 21-hydroxylase enzyme. This is the 21-hydroxylase enzyme. After that, when we have the production of 11-deoxycorticosterone, the 11-deoxycorticosterone will be converted one more time to another active mineralocorticoid. This is corticosterol. Corticosterol. Then the last step is corticosterone being converted to aldosterone. But before we go for the last step, let's talk about the enzyme that's working over here. This enzyme is 11-beta-hydroxylase. And once again, you cannot forget this enzyme. So this is exceptionally high yield, and this is exceptionally high yield. You cannot forget these two enzymes. Next step is, can you guys name the name of the hormone which converts corticosterone to aldosterone? Do you guys remember yesterday I talked about one specific type of hormone which works only in zona glomerulosa that converts corticosterone to aldosterone? The name of that hormone is, what is the name of that hormone? Corticosterone is converted to aldosterone. Very good, angiotensin 2. Angiotensin 2 will activate aldosterone synthase. Angiotensin 2 will activate aldosterone synthase, and aldosterone synthase will convert corticosterone to aldosterone. And that's all that happens in the zona glomerulosa. That's how we get aldosterone from zona glomerulosa. Are we clear, yes or no? Everyone? Okay. Are we clear about this step? Okay. So before I move on to the next step, let me repeat this information one more time. So from our diet, we get cholesterol. Cholesterol is converted to pregnenolone with the help of desmolase. Then pregnenolone is converted to progesterone with the help of 3-beta-hydroxysteroid dehydrogenase. You do not have to remember the name of this enzyme. Next one, progesterone is converted to 11-deoxycorticosterone with the help of 21-hydroxylase. And 11-deoxycorticosterone is converted to corticosterone by 11-beta-hydroxylase. Then corticosterone is converted to aldosterone by aldosterone synthase. And you need to remember only two enzymes, that is 21 and 11. Okay, so that's that. Are we clear about this? Can we move on to zona fasciculata, yes or no? Okay. Can we move on to the next part, the next portion of the adrenal cortex? Everyone? Yes, okay, good. Now, next one is pregnenolone. Let's see let's see what happens in zona fasciculata. In zona fasciculata, cholesterol will not come, meaning that cholesterol will not be converted to pregnenolone. What will happen is that the pregnenolone will be converted to 17-hydroxypregnenolone. 17-hydroxypregnenolone, meaning that there is a hydroxyl group that will be added to pregnenolone at the 17th position. So what should be the name of the enzyme? The name of this enzyme is 17-alpha-hydroxylase. Let me use the blue cursor for the names of the enzyme. The name of this enzyme is 17-alpha-hydroxylase. Are we clear, yes or no? Is everyone clear about this? Okay, is everyone clear about this? Yes or no? The answer is yes. Okay, let's move forward. Next one is over here, 17-hydroxypregnenolone will once again, with the help of 3-beta-hydroxysteroid dehydrogenase, it will be converted to 17-hydroxyprogesterone. hydroxyprogesterone. Either it can be converted via this mechanism, or this can be converted from progesterone directly to 17-hydroxyprogesterone once again by which enzyme? Can anyone tell me the name of the enzyme that will convert progesterone to 17-hydroxyprogesterone by hydroxylizing or adding a hydroxyl group at the 17th position of the progesterone? The name of this enzyme is, one more time. Very good, thank you so much. The name of this enzyme is 17-alpha hydroxylase. So 17-alpha hydroxylase will work either here or either here, it does not matter, okay? As long as pregnenolone is converted to 17-hydroxypregnenolone or progesterone is converted to 17-hydroxyprogesterone, that's enough. Next one is 17-hydroxyprogesterone will be converted to 11, once again, 11-deoxycortisol, not corticosterone, cortisol. But basically the function is the same. By which enzyme? This enzyme. By 21-hydroxylase. Are we clear? Yes or no? Next one is 11-deoxycortisol will be converted by 11-beta-hydroxylase to cortisol. Are we clear? Yes or no? Everyone, are we clear about the pathway in zona fasciculata? Okay, very good. Now, next pathway, zona reticularis. What happens in zona reticularis? In zona reticularis, we have another enzyme that will convert 17-hydroxyprogesterone and 17-hydroxypregnenolone. Okay, it will convert 17-hydroxyprogesterone and 17-hydroxypregnenolone to two things. Either it will convert them to dihydroxyepiandrosterone or DHEA, dihydroxyepiandrosterone, or androstenedione. Okay. The name of this enzyme is 17 17-20 lyase. Okay. This is not high yield, not important. Okay, not important, not very high yield. Next one is whenever we have dihydroxyepiandrosterone and androstenedione, then the process will run very smoothly from here because 21-hydroxylase and 11-beta-hydroxylase, do you think they will work in the zona reticularis? Yes or no? Will they work in the zona reticularis? Yes or no? The answer is no. Very good. Okay. Now over here, androstenedione will be directly converted to testosterone, and it will be converted to testosterone, and it can also be converted to estrogen. Okay. The enzyme that is responsible for converting androstenedione to estrogen is called aromatase enzyme. The enzyme that will convert testosterone to a more potent form of testosterone, which we call as DHT or dihydroxytestosterone, is the name of this enzyme is 5-alpha reductase. We'll talk about this later. It's not important right now. And this one is aromatase. Aromatase. Okay. Are we clear? Yes or no? Everyone? Are we clear? Okay, no. One more time. Okay, one more time. Let's do this really fast. Okay, zona, just 1 second. Okay, now we will do this a little bit faster. Very simple. It's not as difficult as you think this is. Okay, so let's identify the three regions: zona glomerulosa, fasciculata, reticularis. What's happening over here? Number one, first and foremost, cholesterol. Cholesterol is converted to, fast answers please. Cholesterol is converted to which one? Pregnenolone, yes or no? Fast answers please. It's converted to pregnenolone. Pregnenolone is converted to progesterone. Progesterone is converted to 11-deoxycorticosterone. 11-deoxycorticosterone is converted to corticosterone. Corticosterone is converted to aldosterone. Yes or no? Which enzymes are working over here? Over here, we have desmolase. Over here, we have 3-beta hydroxysteroid dehydrogenase, not important. The important one is this one, that is 21-beta hydroxylase. And over here, we have 11-beta hydroxylase. Okay. Are we clear? Yes or no? Okay, let's do this one more time. Let me show you how easy this is. All you have to do is remember the number 21 and 11. And you guys should be good, no problem. Okay, let me show you this one more time. Okay. Can anyone tell me the pathway right now? Please unmute yourself or please write me in the chat box. Is anyone confident to name the pathway of the zona glomerulosa? The more you participate, the more mistakes you make, the more you learn, basically. You learn from your mistakes. So do not hesitate to participate in active participation. Is anyone confident to give it a try? To try this out, zona glomerulosa, what happens over here? Anyone? Okay, so no one. Now, one more time. Cholesterol converted to, fast answers please. It's converted to which one? It's converted to pregnenolone. Pregnenolone converted to, fast answers. Progesterone. Progesterone converted to, progesterone converted to, fast answers please. Converted to 11-deoxycorticosterone, very good. 11-deoxycorticosterone converted to corticosterone, corticosterone converted to aldosterone, very good. Okay, the names of the enzymes that are important is this one, 21-beta hydroxylase, and over here it's 11-beta hydroxylase. Okay. Next one is from zona glomerulosa, it will come to zona vascularis by 17-alpha hydroxylase. Progesterone will also come by 17-alpha hydroxylase. They will be converted to 17-hydroxypregnenolone and 17-hydroxyprogesterone. Then with the help of 21-beta hydroxylase, they will be converted to 11-deoxycortisol and 11-deoxycortisol with the help of 11-beta hydroxylase will be converted to cortisol. Are we clear? Yes or no? Over here, 17-hydroxypregnenolone and 17-hydroxyprogesterone will be converted to dihydroxyepiandrosterone and androstenedione. Androstenedione will be converted to two things. Number one, testosterone and estrogen with the help of aromatase. And testosterone will be converted to a more potent form, dihydroxytestosterone by 5-alpha reductase. Are we clear? Yes? Yes or no? Okay. Now, let's look at this picture one more time. Okay. If there is a patient, okay? Now, is everyone hearing my voice now? I'll talk about some of the most important things that's exceptionally high yield. Is everyone ready? Yes or no? Now, if let's assume that there is a patient who is suffering from a condition where he or she does not have the enzyme 17-alpha hydroxylase. If they do not have 17-alpha hydroxylase, then over here, which one will be high? Aldosterone, cortisol, or androgens? Fast answers, please. Aldosterone. So aldosterone is going to be high. Cortisol is going to be low because cholesterol cannot work over here, and androgens will be low. So in this patient with high aldosterone and low androgens, can we expect them to have ambiguous genitalia or lack of secondary sexual development? Yes or no? Or infertility or lack of puberty or decreased libido, or undescended testis, whatever you want to call this, you can. Because in these patients who lacks 17-alpha hydroxylase, they will not have normal sexual development because of the absence of DHT and estrogen. But they will have excessive aldosterone. So in a patients of 17-alpha hydroxylase deficiency, can we expect them to be hypertensive? Yes or no? Due to excessive aldosterone, because aldosterone will increase the salt and water reabsorption. So patients, if there's a patient, a young patient who comes to you with hypertension and ambiguous genitalia, what is your provisional diagnosis? The first provisional diagnosis, your diagnosis is, fast answers please, what is your diagnosis? Your diagnosis is what? Very good, 17-alpha hydroxylase deficiency. 17-alpha hydroxylase deficiency. Next one. Next one is, if we have another patient who is deficient of 21 hydroxy, of the 21 hydroxylase enzyme, if there is a patient who has 21 hydroxylase deficiency, will there be normal formation of aldosterone? Yes or no? No. So this will go down. Will there be normal formation of cortisol? No. Because if 21 hydroxylase is not there, then this pathway is not there, this is not there, and this is not there. But can there be excessive formation of androstenedione and dihydroxyepiandrosterone by excessive activity of this enzyme because this one is absent? The answer is yes. So can these patients have excessive secondary sexual characteristic, precocious puberty, early virilizations? Yes or no? Fast answer, please. The answer is yes. So in these patients, DHT will be high. But what will happen to the blood pressure? Will they be high or will they be low? Hypotensive or hypertensive? Hypotensive. Very good. So these are patients who have hypotension. Next one is, whenever there's hypotension, should there be activity of the renin, angiotensin, aldosterone? Yes or no? Yes. But renin, can renin activate the aldosterone? Yes or no? By angiotensin 2? If 21 hydroxylase is not there. 21 hydroxylase is not there, then 11-deoxycortisol is not there. If 11-deoxycortisol corticosterone is not there, then corticosterone is not there. If corticosterone is not there, then aldosterone synthase has nothing to work upon. And aldosterone synthase cannot activate aldosterone. So can we expect a negative feedback where renin can also be high in these patients of 21 hydroxylase deficiency? Yes or no? High renin? Yes, very good. Okay. Next one. Next one is very important and a very high yield deficiency. The deficiency is, what if there is a deficiency of 11-beta hydroxylase? Okay. If there's a deficiency of 11-beta hydroxylase, do we have aldosterone? Yes or no? Fast answers, please. No. Very good. Do we have cortisol? Fast answers, please. Yes or no? Do we have cortisol or not? Cortisol, do we get cortisol if 11-beta hydroxylase is deficient? The answer is no. Okay. Do we have excessive activity of this pathway again? Yes or no? The answer is yes. So DHT will be high, estrogen will be high. But what is the anomaly? The anomaly is, if 11-beta hydroxylase is not there, then do we have excessive 11-deoxycorticosterone and 11-deoxycortisol? Yes or no? Yes. Okay. Now, 11-deoxycorticosterone and 11-deoxycortisol has aldosterone-like function. They have aldosterone-like function.
If they have aldosterone-like function, what would happen to the blood pressure of these patients of 11 beta hydroxylase deficiency? Last answers, please. Will they be high or will they be low? Blood pressure. They will be high. Now, let's come to this table. Okay. Now, let's come to this table. Give me 1 second. Okay. Let's come to this table. Let's talk about 3 different types of enzyme deficiency. Number 1, 17-alpha hydroxylase deficiency. Let's talk about what would happen to aldosterone, cortisol, androgens. Let's talk about the blood pressure. Okay, and that's that. Okay. Now, if 17-alpha hydroxylase is deficient, what would happen to aldosterone? Fast answers, please. High or low? High. What would happen to cortisol? High or low? High. What would happen to androgens? High or low? Low. What would happen to the blood pressure? High or low? Fast answers, please. High. Very good. Next one. 21-alpha hydroxylase. If this is deficient, what would happen to aldosterone? High or low? Low. Cortisol, high or low? Low. What would happen to the androgens? High or low? High. What would happen to the blood pressure? High or low? Last answers, please. Low. Next one. 11 beta hydroxylase. If this is deficient, what would happen to aldosterone? High or low? Fast answers, please. High or low? Aldosterone. Low. Cortisol. High or low? High or low? Cortisol. 11 beta hydroxylase low because 11 deoxycortisol will not be converted to cortisol. Androgens, high or low? Last answers, please. High. Blood pressure, high or low? Blood pressure, high. Okay. Now, one more time. You have a patient who comes to you, okay? You have a patient who comes to you with precocious puberty, premature telarchy, meaning early breast development, premature menarche, meaning early menstruation, and hypertension. Which enzyme is deficient? Last answers, please. Which enzyme is deficient in this patient? Hypertension. The patient is hypertensive. Which enzyme is deficient? 17, 21, or 11? Which one? 17, 21, or 11? 11. Very good. The patient is hypertensive. Okay. Next scenario. Next scenario is you have a patient who is suffering from precocious puberty, premature telarchy, premature menarche, and the pressure is 90/50. Which enzyme is deficient? 17, 21, or 11? 21. Okay, once again, you have a patient who has no menstruation as of yet. The patient has no telarchy or no breast development, no secondary sexual characteristic, and pressure is 180/100. Which one is deficient? 17, 21, or 11? 17. Are we crystal clear about adrenal steroids? Yes or no? Yes. Okay. Very good. Okay, good. Today we will keep the lecture up to here because we have to solve some embossed questions. Is that okay? Yes or no? Can we keep the lecture up to here for today? Tomorrow we will finish endocrine physiology and we will begin with endocrine pathology. Right now we will begin with some embossed question. Before we begin with the embossed question, I would like to take a break for 15 minutes. Then let's begin with our daily questions from embossed. Okay. Can anyone tell me why we need that 15-minute break? Why do we have to take a break for 15 minutes? Very good. Which restore neurotransmitters. Not only do you have to restore and replenish your neurotransmitters, I also need a little bit of my restoration and replenishment. So let's take a break for 15 minutes. Let's recharge ourselves. Then let's come back fresh and strong so that we can start with emboss questions. Are we clear? Yes or no? No. So it's 10:55 as of right now. Let's start the class again at 11:10. Okay. 11:10 a.m. Okay. All right. Thank you so much. I'll see you guys at 11:10. Okay, is everyone back from their break? Can you guys hear my voice? Yes or no? Is everyone back from their break? It's 11:10 a.m. Can you guys hear my voice? Back? Okay, good. Okay, good. Is everyone ready to solve the endocrinology questions? Yes, okay, good. So let's begin with today's question. Let's start with 10 questions, see how we do. Eventually, we will pick up the amount of questions we do every day. For now, let's stick with 10 questions. In the near future, we will also increase our class timings and the number of questions we do. So for now, let's stick with 10 questions and let's begin. Is everyone ready with their pen and pencil? Yes or no? Yes, sir. Can anyone tell me how to read US 70 step 1 question? How do we read, or how you should efficiently read a US 70 step 1 question? Please write me in the chat box if you know how to do this. If not, I will repeat myself. Very good. Last part of the question. Start with the last sentence, read choices, and the question. Very simple. Thank you so much, Dr. Ellen, for your answer. Is everyone ready to solve this question? Yes or no? Okay. Let's look at the last line. Microscopic examination of thyroid is most likely to show which of the following. This is a pathology question. We'll talk about this in details in pathology, but for now, let's look at the 5 different types of histology. Either there will be colloids, lymphocytic infiltration, giant cells and non-caseating granulomas, tall hyperplastic follicular cells, or obliterated thyroid follicles and fibrosclerotic tissues. Now, a 31-year-old woman, Gravida 1, Para 1, comes to the physician. 1 week history of heat intolerance, palpitations, and anxiety. During this time, she had a weight loss. Now, she delivered a healthy boy. This sounds more or less like postpartum thyroiditis. Let's see what this is. She has 20 years of type 1 diabetes. Her pulse is irregular, blood pressure is hypertensive, showing that the patient is hyperthyroid. Then you see a fine resting tremor and a painless, mildly enlarged thyroid gland. Okay, please do not give us the answer. Please write the answer in your own page. Can we move on to the next question? Yes or no? Everyone, can we move on to the next question? Let's move on to the next question. Okay, the last one, the hormone that is transported by these carrier protein is most likely responsible for which of the following functions? An investigator is studying hormone synthesis and transport using immunocytochemical techniques to localize a carrier protein in the CNS. Okay. The protein is synthesized with a specific hormone. The protein is involved in the transport of the hormone. So they're talking about which hormone, which protein, fast answers please. They're talking about neurophycins, yes or no, from the supraoptic and paraventricular. Okay. Can we move on to the next question? Yes or no? Is everyone done with this question? Okay, let's move on to the next question. A 56-year-old man with type 2 diabetes comes to the physician for a follow-up. Let's look at the last line. Which of the cellular changes is most likely to occur because of addition of pioglitazone? Pioglitazone is an anti-diabetic. Pioglitazone usually works via a mechanism which we have not discussed as of yet. We will discuss about the mechanism when we talk about anti-diabetic drugs. But very quickly over here, if I have to talk about the mechanism of action of pioglitazone, pioglitazone will increase the sensitivity of insulin and it will activate a very high yield enzyme, which we will learn later. The name of that enzyme is peroxisome proliferating activating receptor gamma. It's called PPAR gamma. We'll talk about this later. For now, please choose an answer and then we will move forward. Can we move forward to the next question? Yes or no? Pioglitazone. Pioglitazone is a type of drug that will increase insulin sensitivity. It will activate a receptor known as PPAR gamma, and it will increase the level of insulin sensitivity and adiponectin. Once insulin sensitivity increases, glucose transport inside skeletal muscle and adipose tissue will also increase because GLUT4 will increase. So please choose an answer. Can we move forward to the next question? Yes or no? Okay, next question. Which of the following findings is most likely to confirm the diagnosis? A healthy 46-year-old man comes to the physician for an 8-month history of headache that is severe in the morning. His blood pressure is high. Examination shows enlargement of the nose, jaws. Ophthalmic examination shows impaired vision. Lab shows a glucose concentration of 225. Can anyone tell me the diagnosis for this one very quickly? What is the diagnosis? This is a diagnosis of what? Not acromegaly, not only acromegaly. Look, why would a patient of acromegaly have high blood pressure? Pituitary adenoma, okay. So let's choose an answer from over here. This could be acromegaly. I'm not sure, we'll look at the answer later. Men, okay. Okay, so this is not men, you guys are correct. This is acromegaly. This is not multiple endocrine neoplasia. Multiple endocrine neoplasia will have sign symptoms of hyperparathyroidism. So they're not talking about abdominal pain, renal stones, or polyuria, depression, or anything else. So please choose your answer. Can we move forward to the next question? Can we move forward to the next question, please? Okay, next question. Which of the following is the most underlying cause of this patient's symptoms? Okay, I think we did this yesterday. So this is, we're not gonna do this today. Okay, this one is the correct answer. Okay, come over here. Let's look at this one. Which of the following is the most appropriate next step in treatment? A 46-year-old man comes to the physician for routine physical, hypertensive, serum shows a potassium concentration of 3.1, plasma aldosterone to renin ratio is high, CT scan shows bilateral adrenal gland abnormalities. Which of the following is the most appropriate step for the treatment? Okay. If plasma aldosterone to the renin concentration is high, is aldosterone being secreted by itself, or is renin involved in the secretion of aldosterone? Last chances, please. Aldosterone and renin, okay, Very good. Aldosterone is being secreted by itself. Okay, so over here, which of the following is the most likely treatment? Please give the correct answer. CT scan shows bilateral adrenal gland abnormalities. Okay, please focus on this one. Can we move on to the next question? A 69-year-old man with type 2 diabetes comes to the physician for a follow-up examination. His only medication is metformin. He has tried to lose weight for several years without success. He is 168 centimeter tall and weighs 110. Hemoglobin A1C is 88.5. Which of the following anti-diabetic drug will decrease the patient's glucose and weight together? Okay. So drugs that decreases weight are usually metformins, anti-diabetics. And we also have another group of drugs, which are called GLP-1 analogs. We'll talk about them later. GLP-1 analogs will also help with weight loss. For now, please choose an answer, and I'll discuss this later. Can we move on to the next question, please? Yes or no? Yes. Okay, good. Move on to the next question. A 36-year-old woman comes to the physician for evaluation of unintentional weight gain, irregular menstrual period. She does not take any medication. She is hypertensive. Physical examination shows central obesity, hyperpigmentation, and violaceous scarring of the abdomen. ACTH is high and cortisol is high. ACTH is normal, I apologize, and cortisol is high. And high dose dexamethasone suppression test will not suppress ACTH. So that must mean that there's something wrong with the ACTH secretion. So further evaluation will likely show which of the following findings. If you guys are done, please write done so that I can move on to the next question. Done. May I move on to the next question, yes or no? Everyone else? Can I move on to the next question, yes or no? Yes, okay, good. Previously healthy 15-year-old girl is brought to the physician by her parents for lethargy, thirst, and increased urinary frequency. Glucose concentration is high, urine is positive for ketone bodies. Which of the following is involved in the pathology of this condition? Okay. Can anyone tell me the diagnosis for this? Type 1 diabetes, very good. But what is the patient suffering from right now? DKA, very good. Please choose your answer for type 1 diabetes. Which one do you think is the choice for type 1 diabetes? Okay, is everyone done? Can I move on to the next question? Okay. Let's move on to the next question. The next question is, which of the following findings would suggest a different cause other than the one described by her nephew? 41-year-old woman comes to the physician because of 3-month history of anxiety, falling, heat intolerance, and weight loss. The patient's nephew, who is studying medicine, mentioned that her symptoms might be caused by a condition that is due to somatic activating mutation of the gene for TSH receptor means Graves' disease. Basically, this question is asking you, which of the following options are not for Graves' disease? Basically, that's what the question is. Okay. Are we clear? If you guys are done, please let me know. Done. Okay. Let's begin with the first question. So over here, a 31-year-old woman, gravida 1, para 1, most probably has postpartum thyroiditis. Let's see what the answer is. The answer for this one is lymphocytic infiltration because of subacute lymphocytic thyroiditis. And these are seen with postpartum thyroiditis. It's a form of subacute lymphocytic thyroiditis. And since postpartum thyroiditis is not due to any activating receptors or an autoimmune disease, it's a chronic disease that happens after pregnancy. And always try to remember this. In any chronic inflammation or infiltration, the cell that you will see is a lymphocyte. So there should be lymphocytic infiltration. So the answer choice is B. We'll discuss this in details later. The questions which we did today are very unrelated to the topics which we have discussed. So if you have missed out on the answers, please do not be disheartened. Please do not be disappointed, because keep in mind, we have not discussed these questions today. So do not worry, please try to learn from them, and let's move on. Next one is, they're talking about ADH. So the answer should be E, that is upregulation of renal aquaporin channels, because they were talking about neurophycins. So this was an easy one. Can I move on to question number 3? Do you guys understand this one? Yes or no? Okay, this is very easy. This one is pioglitazone. The answer is E, because they increase the transcription of adiponectins or adipokines, as we say, adipokines or adiponectins. These are cytokines that basically they regulate the inflammatory response. And this is a part of the mechanism of thiazolidine diones. They activate the peroxisome proliferating activator receptor gamma, which I said before, PPAR. And it increases the transcriptions of the gene. And basically what they do is that they increase the level of adiponectin, and this increased adiponectin, which are decreased in patients with type 2 diabetes, and it increases the storage of triglyceride and subsequent reduction of products of lipid metabolism. So basically what they're trying to tell you is that these patients, these drugs, pioglitazone, what they do is they increase the breakdown of lipids. If I give you 2 scenarios, one, a patient who has high amount of fat, and a second one is a patient who has low fat, which patient has higher insulin sensitivity? Fast answers, please. The patient with low fat or high fat? Fast answers, please. Low fat or high fat? Who has higher insulin sensitivity? Low fatty patients or high fatty patients? Which one? High fat. High fat will result in insulin resistance. Okay, if someone is obese, then there's a higher chance that they can be resistant to insulin. That's why obese patients are more likely to be prone to type 2 diabetes. Yes or no? Patients who are not obese, they have low fat. They have a low fat content. If they have a low fat content, then this increases the sensitivity of the insulin, and insulin can help with the weight loss. So that's that. So adiponectins or adipokines are lipolytic enzymes that are activated by pioglitazone that decreases the lipid content and increases insulin sensitivity. I'll talk about this in details later. Let's move on to the next portion. That is this one. Let's look at the diagnosis. This is acromegaly. This was an easy one. Insulin, increased IGF-1. I'm pretty sure you guys got this right. Let's move on to number 6. This is your bilateral adrenal gland abnormalities. I'm not sure if you guys chose that you would do bilateral adrenalectomy, but if you do bilateral adrenalectomy, then this patient can suffer from primary adrenal insufficiency. So what we will do is we will choose an aldosterone antagonist, which is eplerenone. Eplerenone is also a type of loop diuretic, and it also blocks the aldosterone. So that's my apologies. Eplerenone is not a loop diuretic, it's an aldosterone antagonist. Eplerenone is the same as spironolactone. That is, it's an aldosterone antagonist. So basically what they will do is that they will spare the potassium. So that's that. Since you can see from over here that the potassium concentration is very low, we would like to prescribe drugs that will not affect the potassium. So the choice should be eplerenone and not any other surgical method. If any one of you chose bilateral adrenalectomy, please try to understand if you cut out the adrenal glands of both adrenal glands of the patients can suffer from life-threatening adrenal insufficiency. So please never go for these types of answers. Okay, let's move on to the next one. This one, the answer that they were looking for is a GLP-1 agonist. This is liraglutide. We'll talk about this in details when we talk about this in anti-diabetic drugs. Liraglutide is basically a GLP-1 agonist. They increase the insulin sensitivity and they promote weight loss. So that's that. All the other drugs, they do not promote weight loss as much as liraglutide does. So that's that. Let's move on to number 8. This one, the answer for this one is bilateral hyperplasia of the zona fasciculata, because this patient is suffering from Cushing's syndrome. And when we have a patient of Cushing's syndrome, we know that ACTH will go and activate the zona fasciculata. That's where the glucocorticoids are being secreted from. That's why under histology, you will see that the zona fasciculatas are hyperplastic. So bilateral hyperplasia of the zona fasciculata. So that's that. Are we clear about this? Yes or no? Can I move on to the next question? Yes? Yeah, let's move on to the next question. Next one is type 1 diabetes. So the answer should be T-cell infiltrations, because in patients with type 1 diabetes, it's an autoimmune disease where the T cells attack the pancreas from a very early age. As a result, the beta cells of the pancreas cannot release the insulin, and insulin production also decreases eventually. So that's why patients suffer from life-threatening hyperglycemia and diabetic ketoacidosis. So that's that. The T cell infiltrations of the pancreatic islet cells are your obvious choice for answer. Next one is number 10 and the last one. That is, which one of this is unrelated? The answer is over here. The answer, the choice is Graves' disease, but the question was which one of the following findings would suggest a different etiology? Over here, the only answer option that we can see is a non-pitting edema, as you can see over here. Non-pitting edema is something that happens only in Graves' disease and no other disease. The reason being is because Graves' disease, you have TSIG, that is thyroid stimulating immunoglobulins, that can go and activate the glycosaminoglycan synthesis in different portions. That's why patients can get non-pitting edema and exophthalmos. As you can see over here, they did not mention exophthalmos. So the answer is non-pitting edema. Are we clear? As you can see, exophthalmos over here and non-pitting edema. So for Graves' disease, always try to remember a patient with hyperthyroidism, if they have Graves' disease, then they will have non-pitting edema. Patients of hypothyroid also have non-pitting edema, but the hyperthyroid patients who are diagnosed with Graves' disease will also have non-pitting edema. Okay. Are we clear, yes or no, about the 10 questions for today? Yes. Okay, good. Now, homework. Okay. Can I give you guys a short homework, please? Yes or no? Okay. Homework is this one. This is your homework. Adrenal steroids and congenital adrenal hyperplasia. Are we clear? Yes or no? Okay. So tomorrow we'll take a much lengthier and a longer class. The class will start at 8:30 and it will extend till 12 since tomorrow is the last day of the week. It's Friday. We will finish endocrine physiology and obviously move on to pathology, but we will not start the class without being sure that we have learned adrenal steroids and congenital adrenal hyperplasia. And I expect every student to participate in active participation. Have I made myself clear? Yes or no? Okay, perfect. Okay, so thank you so much for joining the free lecture. I really appreciate it. Before I leave today, just want to say one last time about, I just want to talk one last time about Usmle Step 1 as a whole. Usmle Step 1 is not a very difficult exam. Usmle Step 1 is a very lengthy exam. You have to have a certain level of knowledge and you have to have the patience to solve questions for 7 hours straight. It's a one-day exam for 8 hours. You will get 7 blocks. In each block, you will get 40 questions and 1 hour to solve each block. So in order for you to do this, you have to have the ability to solve a lot of questions. So my advice to you guys is if you are serious about your Step 1 exam, number one, please try to make sure that you continue the classes, you continue our classes. If you feel that you're confident to read the book by itself and you do not need the help of a tutor, then you're welcome to try to do so. But the thing is, the advantage of doing the classes with us is you can directly read the first aid. You do not have to use other resources. You have other resources such as Boards and Beyond. You have other resources such as Sketchy and all of those things. Every other resource except first aid is created to make sure that you can understand first aid better. Because once again, every question in Step 1 is created from the first aid text. So the advantage of doing classes with us is you can directly skip all the resources and focus only on understanding first aid, because that's the primary goal. And after understanding the text, you have to incorporate the knowledge by solving questions. And that is from UWorld and UWorld only. The questions from AMBOSS will be solved in the class, and you have to solve the questions from UWorld at your own time. If you have problems solving UWorld questions, then you can always come in the class with the questions, and I'll try my best to help you guys understand. Okay, so that's about it for today. Thank you so much for joining the lecture. Please make sure to complete the homework before you come to the class tomorrow. Your Step 2 CK classes will start at 1:30 p.m. today. If you are interested to join the Step 2 CK classes, please send us an email or connect to or send us a message in our page on Facebook. If you have friends who want to start Step 2 CK, please send them a message and ask them to join the Step 2 CK class at 1:30 p.m. If you have time to join the Step 2 CK classes while preparing for Step 1, that's also very recommendable, because we talk about similar things in Step 1 and Step 2, but a little bit of more of a clinical approach to the different sorts of subjects. So you're more than welcome to join since the classes are free. And that's that. Do you guys have any question for me? There's one question from a student who has a doubt about dopamine. It decreases both prolactin and TSH. If you can clarify, dopamine will primarily decrease prolactin. It is not directly linked to TSH, but in long-term dopamine secretion, TSH secretion will also decrease. But in short term, if you prescribe dopamine, TSH will remain unaffected or TSH might increase a little bit. So to answer your question, dopamine decreases both prolactin and TSH, but short-term administration of dopamine will increase TSH and help with hypothyroidism. Are we clear? Yes or no? Okay. With that being said, do we prescribe dopamine for the treatment of hypothyroid? The answer is no. But do we keep patients in check who are being treated with dopamine? The answer is yes. For example, in Parkinson's, if we prescribe levodopa and carbidopa to a patient for a long period of time, then we need to keep their thyroid hormones in check because long-term administration of dopamine will decrease TSH. Okay. Hope that answers your question. Thank you so much. Does anyone else have any question before I end the lecture for step one? Does anyone else have any question? If no, then I will take my leave.
Yes, doctor. I want to register for next class. It's my first time.
What was your question? Could you please repeat that question one more time?
No, I want to register for the next time.
Oh, you want to register for the next time? Yes. You received the email for the free class, right?
No, Dr. Abu Riash and Abu Zayed told me about it, and
you received recommendations from Dr. Abu Riash? Yes.
Yes.
Okay. So thank you so much for joining the lecture. I really appreciate that. Now, can I get your email over here very quickly so that I can send you the link for tomorrow's class?
Yeah, I'll send it to the chat.
Yes.
Okay.
Okay. So leave your email address. Does anyone else have not provided me their email address? Is there anyone else who has not provided me with their email address? If you have not provided me, okay, so can I get your email address too, so that I can send you the link for tomorrow's class? If there is anyone else who has not provided me with their email address, please leave your email address in the chat box and I will be sure to add this to the class for tomorrow. Okay, so thank you so much. Okay, and the rest of you guys, thank you so much for joining the class. I really appreciate it. The class for tomorrow will be at the same time, 8:30. I'll take the class a little bit longer since it's the end of the week. I'll take the class till 12. Please try to make sure you complete your homework about the adrenal steroids. And I'll see you guys tomorrow at 8:30. You are more than welcome to leave. I'm just gonna take 5 minutes to add the email address. That's it. If you have queries about timings, then our classes are taken at New York Eastern timing. So all you have to do is go to Google and write down what is the time in Russia for 8:30 a.m. in New York, and you can see the timing. Okay. So that's that. Okay, so thank you so much. Yes. Is there anyone else who has a question?
I think, sir, wanted to ask you about the time, sir. If you can send the email before class, I think it would be appreciated because before class, it will be just like, sir, arranged for us. So there will be no confusion. I mean, with time. We will join the class on time. Today, I joined the class very late because of time difference. I didn't know about that. So
Okay, so you didn't know about the beginning of the class because of the time difference. We start the class at 8:30 a.m. in New York Eastern timing. Where are you from?
Sir, I'm from Russia.
From Russia. Okay, so let's see what your timing should be. So 8:30 a.m. New York time to Russia time. Okay. Let's see. Okay. So if it's it should be around 4 p.m., 4:30 p.m.
Sure, sir, no problem. But I mean that sir, if you can send the link or through email just before 10 minutes of class, sir, then it would be really appreciated, sir. There would be no confusion then.
Oh, you're asking for a reminder before 10 minutes, the class, before we start the class, 10 minutes before?
Yes. Yes.
Okay, I have sent the reminders today at 8:20 a.m. Have you provided me with your email address? Yes, you
Yes,
have.
sir.
Okay. So tomorrow, before we begin the class, you will receive another reminder 10 minutes before the class begins. Okay.
Sir, thanks for help. Thank you.
You are very welcome. Thank you so much. Hope you have a great day. I'll see you guys tomorrow at 8:30 a.m. Okay, bye-bye.